Almagini is excused. Dr. Gerling,
Yep, here.
Dr. Katz. Yes, I see him. Dr. Mulvey is excused. Dr. Pond,
I'm here.
Dr. Rogers is not. Dr. Starr,
Dr. Starr resigned.
okay, we'll get him off the list. Thank you. Dr. Williams, Patty Bashaw, Tammy Trombley.
I'm here.
I just heard a mutter. We have.
I'm
quorum.
here. I'm sorry. Did you hear me?
Yeah, thank you. All right. So did everybody get a hold of the minutes from the last meeting? And do we have a
Hi,
motion to?
I'm sorry to interrupt, guys. This is Mike Durso. I am here partially because I'm working an ER shift right now. I'm sorry I was able to actually get on.
Welcome, Mike.
And this is Molly Furran. I'm also here.
Yay, thank you, Molly. Excellent. Okay. Everybody's had a moment to review the minutes, or lots of moments, actually, exact something out for us. Do we have a motion to approve the meeting minutes from January 2024?
I'll make the motion.
And a second, please?
I'll second.
Any discussion of the minutes? Any opposed to approval? Okay. I'd like to introduce first, because he's on shift, Dr. Michael Durso, who is pending our approval for acceptance onto our REMAC. He is the medical director for Champlain EMS, Clinton, and Ellenberg Center. And Mike, who else do you have? That's what I have in my head.
Altona and as of very recently, Dannemora.
Congratulations.
Thank you.
We all have had a chance to take a look at Dr. Durso's CV, which is more than adequate, I would say. And Michael has been doing medical direction for most of these agencies for at least 6 months. And they've been giving him happy, excellent reports. My little spies are out there telling me that he's doing a great job, so I'm really grateful.
I'll make the motion to approve him.
Thank you. Do
I'll
we have a
second.
Any discussion? Any opposed? Okay, motion passes.
Michael, can you just, before you get called away, we just talked a few minutes ago, you're all set with the 2 ambulances that are up for renewal. I just want you to say that publicly, so when we get there, we're good.
Yep. Yeah. So Champlain Moores EMS and Town of Clinton EMS. I think they're in great standing, and I approve renewal for them.
Sorry, Tiff, I just wanted to get that in.
Don't be sorry, that was great. Thank you very much. I apologize for splitting my focus. Dr. Williams is here and needs to be let in. Zach, can you or somebody let Dr. Williams in? I think he's upstairs.
Yep.
Okay.
We'll put him on my way back.
It's a left to you. Yeah, right-hand search when you come downstairs. You'll be okay. Okay. Let's talk about Dr. Furin next, because she's driving. Hopefully she can still hear us. Molly, you still there?
Yep, I'm still here.
Molly also comes from a rich EMS background, and she is taking over from Morrisonville EMS, which is pretty exciting. They are pretty excited to have her. We've seen her CV. So, any discussion of Dr. Furin?
I'll make the motion to approve her.
Oh, Dr. Pond.
Can I just mention something? Not that I have any problem with these applicants. They all look hugely qualified, but We are supposed to kind of have a ability to discuss when the applicants are not online. Otherwise, this is just a rubber stamp approval purpose. I'm happy either way. I'm hugely in favor of bringing these applicants on. They look outstanding, but I just want to make sure we adhere to our own rules and our own system of checks and balances. That's all. Thank you.
Yeah,
so
Doug,
great.
Doug, I agree with you. We just have to come up with some way to do that.
You're absolutely correct. I'm so sorry. And you know what? We've had this problem before, and I think you were the one who reminded me then too, and I still haven't kept it in my head. Zach, do you know a way that we can sequester people on video just for a few seconds to talk about them behind their back?
We can kick them out of the meeting, but then we would have to have a way to tell them to come back on.
Yeah, that's my question is how do we do that? I don't know.
So let's just have them sign out and then come back in 5 minutes.
Okay, sounds good.
Because
Okay, thanks, Bob.
they have to get approval to come back in, right? So you can hold the approval.
They can come back in, but we can kick them back out if we have.
I'll tell you what, I'll text you guys when we're done talking about that. Dr. Where are you on?
Get-
Have you-
Yeah, I'm on. I was flushed momentarily.
Oh, that's wonderful.
Can I ask, for this doc, is she a service medical director? Is she taking some ambulances?
One second, Dr. Pond. Dr. Laporte, can we have you leave the meeting for us for just a couple of minutes? We'll text you when you can come back.
I have to go put some
Okay, I'll
stitches in a
leave it.
patient. I can try to run and do that and then come back in as soon as I'm done.
Yeah,
That's
I
perfect.
think,
Thank you, Mike.
and they should stay on just in case we have any questions, and then they can literally leave for a couple of minutes while we
Yeah.
vote, and then we're done, right? So
I'll
I
try to
guess,
come back in 10
yeah,
minutes. I'll
perfect.
be back.
So does anybody have any questions for any of the applicants before we have them sign out? Going once, going twice. Okay, I guess we're probably all ready to vote, so we'll just do a sequester for a couple of minutes and then
All right.
resume normal business.
Thanks. Be right back.
Thank you.
The one thing I want to just ask is to make sure that these people coming on have either represent a hospital or represent a service. So is Molly taking some ambulance services?
She's taking Morrison. She's
Okay,
taking
good.
Morrison. And I think she was talking about taking another one as well. I'm not sure which one.
Okay, I have nothing. I think we should approve them.
Dr. Laporte is the third one for approval. He does not have EMS experience. He's the only one of the bunch that does not, but does have a rich emergency medicine background, trained at Upstate, and so has a little bit of an EMS experience from that perspective. I've known Dr. Laporte for quite a while. He's honestly lukewarm about taking on this role. However, I think that we can prompt him to do the job, at least until he can hire someone else to do it. He has taken over the medical director role at Adirondack Medical Center in Saranac Lake. So we're really excited to have a representative from that hospital again. That's pretty awesome. And and correct me if I'm wrong, Dr. Pond, he's going to be taking over Saranac Lake and Tupper and Paul Smith at some point. Dr. Pond and Dr. Reporter working on a dovetail that.
Yeah, we can just talk about it for a second here. I took on Tupper Lake, Saranac Lake, Paul Smith. 2 ambulances are out there that don't have medical directors, Long Lake and St. Regis. I took them on a couple months ago between our last meeting and now because they didn't have a medical director and haven't had a medical director for years. Tiffany arranged a meeting with Dr. Laporte, Fred, and I made it very clear I wasn't going to accept all the Tri-Lake ambulances and that we needed Tri-Lake's quality assurance. He's the ED director. It's his responsibility. Tiff was very direct with him as well. And we're happy to have Adirondack Health involved now. Hopefully, I have put an ultimatum in us that September, I'm moving these ambulances unless we work something out. I've got enough ambulances and enough stuff to do. He's agreed to that as it stands. So that's where we're at with him. I would vote to approve him, and we'll sort this out with some time.
Any other discussion about these guys? All right, tell me where we left off. Did we approve Dr. Furin?
I'll
Or sort of in-
make the motion to approve all three of them in one motion.
Works for me.
Okay,
Second?
and I'm good to second that.
Simple. Any opposed? Okay, pardon me for texting and talking at the same time. I'm trying to text Dr. Cardos about West Glen Falls because their license is coming up.
Wait, John.
So.
She's not the
trying
medical
to-
director for West Glens Falls.
George, sorry, I
Question.
read off my list.
Hey, George, okay, yep.
Nick George, my apologies. All right. I'm gonna have to put her off for a second because we've got the CMAC report. Okay, on May 8th, we had the med standards
back.
meeting. Hello, thank you for coming back. And let's text Dr. Laporte.
That was.
That was Dr.
Oh, that was Dr. Laporte.
That was like the.
You're in.
You never heard my voice?
I should. Okay. Yes, Dr. Pond, what's up?
I was just gonna say I could text those people for you so we could move on.
We're moving. I found it. So med standards, the BLS iGel project is ongoing, which is placing supraglottic airways by basic EMTs. Any agency can get involved in that if your agencies are interested. It's a great way to control an airway when you don't have an ALS provider on hand. And you can email me or text me if you're interested in that information. I can get you in touch with the right folks. There is some documentation, kind of software structure changes called Nemesis 3.5 that's supposed to streamline the documentation across all the vendors. So if you're an EMS charts agency or image trend agency or whatever your software is, this is supposed to make it smoother so that we can gather information out of all that better. And so it's easier to use by the providers. I am trying not to editorialize about that. Okay, moving on. If you're involved in the EMRs, you understand when my head's sort of aching right now. There has been an ongoing discussion over the last several CMAC meetings about integrating EMS electronic medical records into the hospital electronic medical records, and to try and draft some legislation and actually get that idea passed into New York State law, so that the information that our EMS providers are collecting and spending a lot of time and effort collecting, that's valuable information about our patients, is actually visible in the hospital medical record real time. So when I open up a patient chart, I can see the triage note, I can see the EMS report, I can see the EMS EKG, all of that should come into one medical record and end up on my screen, right? I think we can all agree that this is the way life should be. However, this costs people time and energy and money. And so we're going to try and put it through the New York State legislature to make this law that this has to happen, so that maybe we can get a little more force behind that, which would be really exciting. So we had a bit of a discussion about that. That's an ongoing project. Mike, did you have something?
No, sorry.
It's okay. I could hear you there, so I wasn't sure.
No, I'll mute myself. I was, I'm sorry.
Oh, it's okay. The Blood Products Administration for ground ambulances fight is still being fought. There's an action group that's being formed to draft like how to implement that, so that when it's ready to move forward, it actually moves forward. That's again caught up with the state. But the CMAC certainly approved it, I think 2 years ago now. There was an interesting informal study done at the New York State Police, where they, for 1 year, substituted 8 milligram nasal naloxone for 4 milligram nasal naloxone in 3 of the troops. So 3 of the sections of the New York State Police used 8 milligrams, and all of the rest of the sections of the New York State Police were still using the 4 milligram nasal spray naloxone. What they found was that they had 99% survival in all groups. However, what they did see was the 8 milligram was associated with a lot more vomiting, and other symptoms, non-categorized, right? So withdrawal symptoms, right? The withdrawal was worse when we gave more, and the outcomes seemed to be no different. There was a push from New York State, i.e. the legislature, somewhere was pushing to put a long-acting, stronger form of naloxone on the street for EMS. And that's called nalmefene. Wasn't something that I was familiar with, so pardon my reading. And based partially on this, informal study by the New York State Police, we felt like, hey, not only should we not be using 8 milligram naloxone, we shouldn't be using something stronger, right? 4 milligrams is doing the job. We should probably stick with what works. Increasing the strength, contrary to popular belief, does not, help with xylazine and help with, all of the other like additives, bromazolam, all that stuff that's getting added onto the fentanyl and the, other opiates that we've been familiar with. So why are we messing with this? So we, as a med standards, passed along to the CMAC, who also approved it. We said, no, this is not something that we're interested in. But you guys should know about it because it's something happening in Albany, right? And when people talk to you about it, it shouldn't be the first time you've heard about it.
Can I add to that real quick
Yeah,
too?
please.
One of the things that they said at the meetings too, and we see this a lot on the North Country side when it comes to narcotics and pain management, of that idea of pain-free, not tolerable. It's the same with Narcan. You want them to get their respiratory drive back. You don't necessarily need them to completely wake up, then go psychotic in the back of an ambulance.
It was also associated, though, remember, with worse outcomes down the road. So, and I think that was more telling to me than anything else, that people who came up hard with naloxone, with 8 milligrams of naloxone, often tended to go and then use alone as opposed to using with other people, where they would be protected and safer. And they would go off because they didn't want that 8 milligram dose. So that was problematic. And I think that was more telling to me, that I would prefer that if we're going to give it, that we give it in amounts that just brings their respiratory drive back and not put them off using Narcan totally. And have worse outcomes in the long run. So I think that was
Well done. Yeah. There was a phrase that was coined while we were there that was batted around quite a lot that I loved, and it was respiration, not conversation. So what is our goal of care, right? Respiration, not conversation. And I'm stealing that. I thought that was very smart. The other phrase that I probably shouldn't put publicly on camera, however, I'm going to because it was amusing and illustrative, is naloxone waterboarding was discouraged, right? Which is not particularly politically correct, however, very funny. And we've all seen this happen, right? Where, it seems like people are spraying gallons of this stuff. It's not really, but it's a lot, right? Keep spraying, keep spraying, keep spraying until you get some sort of reaction. Well, sometimes that reaction is just a reaction, all that spray up your nose. It doesn't have anything to do with opiates. So that was interesting. Okay, so that was pretty much it for new things on med standards. I will remind you the new protocols are coming out. I think they're due to be approved July 1st. So that's coming to an EMS system near you. There are several protocols in there that need your personal approval as an agency medical director for your folks to do it. So the phrase is if equipped and trained and approved by your agency medical director. Okay. The CMAC. So at the last CMAC meeting, there was a lot of discussion about the sunsetting of the critical care EMT which is now planned for 2027. There's been a pretty big uptick in bridging people from critical care to paramedic now that that deadline has been issued. Currently, there's 63 students in the bridge course, which is great news. That's more REMSCO. I'm trying to pick through the stuff that's actually interesting to you guys in particular. There was an interesting study that was done by one of the services down near New York City about medication dosaging in pediatric patients. And what they were finding was that their medication, when they studied this case by case, the medication dosing was rarely correct, really. But, what they didn't discuss with us was how incorrect was it, were these dangerous doses or not. Regardless, what they did was they bought the hand-heavy system, which I don't know if you guys are familiar with. A bunch of years ago, Peter Antevy came up for a REMAC meeting. I don't know if you remember, Zach's nodding his head. It's one of the ones we had at like Placid, and actually ran this up the flagpole for us. And he has invented a system that's similar to PDStat and similar to Braslo, but it's an app. It comes with a measuring tape. And what happens is it does your drug calculations for you, and it's tailorable, right? So it will do the drug calculations correctly that are in your actual protocols, and not give you things that, like, if you use a Braslo tape, half the medications on a Braslo tape are not the ones that our EMS providers are using. The doses are correct, but a lot of the medications that our EMS providers need a Braslo tape for are also not on the tape. So you need something else. There is a weight calculator at the end of our protocol app. It doesn't do the calculation for you, but it is a little weight chart, which is helpful. So they found a lot of improvement, obviously, when they use this tool. I would certainly encourage you guys to have a look at it if you're interested. The other one, like my services use the PDStat app, which I think is $5. And you plug in a weight or an age or a Braslo tape color into the app, and it spits out numbers for you and tells you how much medication to give. So that's what I use, and it's what my services use, and it's cheap, which is nice. And I think that's all I've got from CMAC. Do you guys?
I can rattle through some quick SEMSCO stuff, and Storm, if I miss anything, just tell me.
Thank you.
So they're looking at new structure for blood. So there is a bill right now in the state assembly, A5789, and it's gaining a lot of movement. The session closes though next week, so they're really hoping to push a lot of that through. TIP and CAT, which is the treat in place and transfer to alternate destinations bill, is being pushed. It's in the Senate and the Assembly right now. And that is so ambulance agencies can receive reimbursement for going to alternative destinations and treating in place. So if you have a patient who's having a mental health crisis and you have a mental health urgent care that is in your community, they can transport to a place that is more appropriate for the patient, especially if the hospital is on psychiatric diversion. So if that goes through, that'll be a really big win. There's an advisory out for LifePak 15s, Phillips and Zoll pediatric pads from the commission's office, basically saying make sure that you're using the appropriate pads for the appropriate machines and don't use a generic pad for these machines because they will possibly not deliver the right amount of charge to the patient. You talked about that. So there will be state funding that's going to come out attached to the program agency contracts, and we don't know exactly what it's going to look like to put 2 people through paramedic school per region. So we'll be able to do 2 students from the Mountain Lakes region, 2 from the North Country, and it will pay for their tuition. Any money that is left over above and beyond that tuition, we can take and use to either buy books for somebody who didn't get the full scholarship, if there's funds left over. They're looking at doing a statewide kind of curriculum, or not curriculum, but requirements to be able to have people go through that, so we're not all doing it differently. What else, Storm?
Yeah, and that was interesting because they're really looking to replace, so they plan on building these paramedic reserve groups, and I think that that's what this is aimed at, is instead of pulling away from your agency, their plan is to replace in your agency, and then use the providers that are already existing, which was kind of what I got from it, right, Zach? That's their plan, anyway. Or at the time, that was their plan. So I think that that's at least a little better than just saying they're just going to give us 2 paramedics in each region, maybe if we get them through the court.
Yeah.
Kind of thing. And
they're gonna also do some recruitment and retention funds. It'll also be funded through the program agencies to distribute out. Their main reasoning behind that is they didn't wanna put it into the REMSCO's contract and then bump them a tax bracket and make them have to do a whole bunch more tax-wise, where they already give us enough money that we're already having to do so much for doing our taxes that it really didn't make a difference to give it to us. Vital Signs is in October and it's in Rochester this year. And to speak to the reports that Dr. Bombard was talking about regarding the med dosage errors for PEDS patients, we're actually going to work with the doctor from the Melrems region who designed all of these reports and build them for our big region of the North Country Mountain Lakes area to be able to give that information back to you docs so you can see what is going on with your agencies. Are these actual med errors? Is this a documentation error? Where these problems are coming from, and see how we can move forward to fix them, or what we can do to fix them.
Or if we need to fix them,
Or
right? Like if they're off by a smidge, I'm not too.
That's a
concerned
margin
about
of
it.
error.
If we're moving a decimal point in the wrong direction, that's a problem.
That's all I've got. Ed.
You there? I saw him earlier.
Yes, he's there. I think he's unmuting himself.
Okay.
Yes, excuse me. Good afternoon, everyone. From the Bureau side here is from the perspective, everything really has been covered. Jonathan, is there anything in particular you wanted to have answers to related to? We have the EMS Memorial that's been moved to September. You've talked about vital signs. You've talked about the meetings and we are moving the location from Troy to Saratoga Springs is going to be the new location in September. Just keep that in mind. From the perspective of operational updates, we have added, we've backfilled a couple positions. We've announced those. We've had a promotion of Don Trepes. He's moving over to EMS agency licensure, so he'll be the branch chief there. We have added in the Syracuse Central New York office, Vinny Wiemet. He's joining us. He's in training. We hope to have a waiver coming through in the, I'll say near future, state time. We'll see where that comes, but we're going to have a good amount of new positions from the field staff that were approved in the budget. We'll see how those come out. Obviously, state task force is a big piece of the momentum that we are moving forward with in the next year. So our staff has been approved for, I think, 152 positions overall. Bureau director is extremely happy about that. We've got a lot of work to do, and we've got a lot of onboarding to do, and hiring wave will be coming. There's also a lot of initiatives to backfill those paramedic positions and put on additional training. One of the big things is there is a aid to localities that went out to all the counties related to specific projects, up to $5 million per county, something to that effect. I'm not the expert on that. However, there's good momentum related to some funding capabilities that could be used for a variety. We can't necessarily discuss that with any of those particular counties, but they've all been reached out and provided the information from our budgetary team and what the RFA is and those kind of components. So, Jonathan, is there anything else? Are there any questions or anything that you wanted me to cover in particular, or if there's anything? Happy to answer any questions. I believe we've got Melissa, I think Vinny is on, Alex may be on. Again, we are hoping to get another sort of a North Country rep. We did have a position that was open for Watertown in particular. We reassigned that to Syracuse, and hopefully the backfill for that position will be coming, and we'll have somebody that's sort of embedded into the area. Right now, we've got, I cover as the branch chief of the Mountain Lakes REMSCO and certainly the REMAC side. We've got sort of a split. We've got Alex Kazar, who reports to Rich out of Merrow, but he's been sort of covering Mountain Lakes. So if there's any operational or any BEMS related matters that need to come forth, please feel free to reach out to me or Alex at this point. And we're having some staff modifications, and we'll keep you guys updated on that. I did send out a sort of a zone coverage memo to the different program agencies related to who's covering what counties and those kind of things. So if anybody got any questions, I'm glad to help. Or if any other staff, Melissa, Alex, Vinny, if there's anything that you guys wanted to say or communicate, please let me know.
Perfect.
Excellent. Thanks, Ed.
Thanks, Ed. Program agency report. I did have one question, if that's okay. I know I've got to jump off because I've got an appointment soon, but I know there was previous discussion on some interfacility protocols, those kind of components that were coming up, and I did send Jonathan and I sent him a response to those. So I think that I know there was maybe some discussion from the perspective of whether those were what the approval requirements were, and the expectation would be that those get approved at the REMAC level. Then they go up to the state council to medical standards, obviously the collaborative group, that kind of thing first. Then it goes to medical standards, and it would ultimately be approved by the CMAC and SEMSCO. So I just wanted to make sure that that was clear. If there's any questions on it, I'm happy to answer them prior to me jumping off, but I did want to make sure I followed back up on that. So thank you.
Ed, I don't think that's actually correct. That's correct for 911 protocols, but the CMAC has been pretty unequivocal about interfacility protocols. I can.
Yeah, we could talk offline on that. I mean, if these protocols have been previously approved, and I know that there's some gray areas, certainly related to that, and we do look at it as a protocol. Other regions, certainly Western side, they have put it up through for approvals. I think that I understand that there could be some variances and there's some discrepancy related to the actual interpretation. I could certainly get an opinion from DLA to, in a sense, evaluate that. But with the recent changes, if these protocols have been previously approved, or if you're adopting that of, like, I'll give you an example. Melrems has an SCT interfacility protocol that went through the entirety of the process. If they've been previously approved, you can adopt them. But our position would remain strong that they should go through an approval process and to be reviewed. But I could certainly refer back to the Division of Legal Affairs and go from there. I understand that there's some grayness in there for sure, and I appreciate that feedback. But I think from the overall evaluation, it would be considered a protocol. It's still occurring in the back of, and I know that the sending facility has ultimate responsibility for the patient for the continuity of care between the two facilities. We talk about medical control and those other aspects. So I could certainly take that back and get some additional clarity. But we have sort of required that in other regions, and I still hold that position.
At the, not the last CMAC meeting, but the one before, there were some interfacility ground transport protocols that were introduced that were actually just thrown back because the CMAC felt that this was not something that was their responsibility, and that it was responsibility of the REMACs to approve the regional interfacility protocols, not 911.
Right, understood. Okay.
Then that does not apply to flight. Flight is a different category.
Correct.
The
We've got
ground
flight.
transport, facility transport protocols were introduced to the CMAC, and the CMAC said, no, this is not our job. We don't approve these. These are approved by the REMACs, and that's as far as they go. Now, I would absolutely welcome you running that by legal. It'll have to go back through the CMAC, and they can also decide what they want to do again.
Right.
But I encourage you to review those minutes because they were quite clear. And I had
Yeah,
nothing to
no,
do
I
with that.
understand. I appreciate that feedback, and I'm not trying to be difficult or anything to that effect. Obviously, we want a patient-centric approach and to ensure that local parameters are taken into account. And I know, but I will take that back and get absolute clarity as to the inclusion criteria, et cetera. So I appreciate that. I wanted to bring it up, and I think it's good discussion because I think that it should be evaluated and go forward from there. So thank you.
Okay. Oh. So New York State policies updates. So there's 4 new policies. They're the BLS protocol change law, the collaborative protocol change law, EMS course requirements for hazmat response education, because they found what we were teaching before did not really tick all the boxes of what they should be learning. And then the EMS instructor certification process and requirements policy statement. They are continuing to work on updates for the EPCR policies 1202 and 1203. They've kind of hit a back burner right now because we are working on the NEMSIS 3.5 update, and that will kind of draw a picture of what that is going to look like. I will say, though, that with the EPCR policy, there is probably going to be some regulation drafted with it as well, that is going to give the state a bit more ability to be able to go after, I shouldn't say go after, but to enforce the timelines for EPCRs. Currently, it's 4 hours or the end of your shift. We've been starting to run reports out of our office that we have charts that it's taking over 600 hours to complete. So that's a month for people to complete a chart. This is a patient care report. This is a legal document. Like, you can't sit and wait for that. That's terrible. So the EPCR schematron was updated on 1/1/24. Implementation of the software by vendors will be July 1st. There is no wiggle room on that from the state. PAD usage reports, we didn't receive any. We did not receive any new applications either. Updates from Washington County, 7 locations, and Hartford Central School, and the usual reports were received. BLS iGel study applications, so we received them from Malone, Foothills, Moira, and Elizabethtown Lewis. So they are, that's what I said. Did I say that wrong?
And they're doing it in 2 agencies in Clinton County.
What's that?
2 agencies in Clinton County, so Champlain and Eastville.
These would just be new ones since the last meeting, so it's
Okay.
not a running list of all of them.
Oh, we can provide that to everybody after. But so DOH courses coming up, Clinton Community College, an EMT original and refresher, starting in June. I don't know my month, sorry. EMT original and refresher starting in August, and an AEMT original and refresher starting in August as well. NCC is an original and a refresher in Ticonderoga starting this month. And Queensberry EMS and EMT original started in April, and EMT full, refresher full and challenge upcoming at Fort Edwards, which starts in June. So PEC, it's not just for EMS agencies. So all the EMS agencies, we really need to have a PEC coordinator, so a pediatric education coordinator. So if your agencies don't have one, please point them our direction so we can get that set up. Amanda's contact information is there on the page. But they also, facilities should have them too, because it's a good way for us to make sure that we have that continuity of care between the field provider and the emergency department.
And even if you aren't a PEC, there is a survey out right now that the state would like every agency to complete. The link can be found on our blog on our website.
Training and education. So there, we have the learning management system. If your providers haven't registered for an account, they should. That's the website for it. So we recently added a snow, dirt, it still hurts, all terrain trauma, a loud value lecture for EMS providers. We're working on a geriatric lecture, BLS pharmacology learning path. So the really cool thing with our learning management system is we can actually break it down into 15-minute videos that are like a micro series and tie it all together. And you can assign that entire micro series to your providers at your agency. And they can do it on their own time. It still equals out to what they need for their refresher, but it takes it and breaks it down into more digestible means. We are working on an ALS pharmacology. We're just kind of working our way through how to break that down. Do we break it down by class? Do we break it down by what it's used for? So we're still trying to figure
I
that
did
out.
use, when I did my lecture,
Use?
I did it by use. I think it's easier for them to comprehend and put medicines together in little pods. So I thought that was very helpful. And I think the students did too.
Nice. June 27th, there's a first responder child abuse training webinar that we'll be hosting. Registration will be opening soon. We'll make sure that gets out to our listserv and we'll send it to everybody. We are working on planning a Mountain Lakes Education Day, where we're gonna come over. We are an ACLS and PALS instructor site, so we have all the equipment to do that if that is requested. Or not PALS, sorry, ACLS. But we're just going to offer a day of education and CMEs. And then Spring Fling 2025 will be April 10th, 11th, and 12th. This year.
So the CQI initiative is still ongoing. So high call volume agencies. All right, it's 5 charts reviewed quarterly. Low call volume agencies are 5 charts. And they will be selected once a year. We missed April because everything was a little busy with Spring Fling and we were down a staff member in our office. So the PCR uploads did not go out for April. It will be for May to each agency to make sure that the number of charts they generated matches what's in the state bridge. This is the quarterly overview for the CQI initiative. So there was a total of 265 charts that I reviewed. 136 were from Mountain Lakes and 129 were from the North Country side. The blue line is the overall between the two, and then the orange line is Mountain Lakes. Charts are severely lacking assessments in both regions. Charts either don't have them, they have like just mentation, people aren't listening to lung sounds for difficulty breathing calls. Trauma injuries have no assessments. The assessments are rough, and I'm looking for like a drop down or in the narrative. So neither portion of the chart has any assessment.
So one of the things that came out of this is we are going back and looking at the software vendor for those particular agencies and seeing if it's actually a mapping issue, that it's not pulling over the assessments, or if it's truly just not getting done.
And I have noticed some mapping issues. So a couple agencies use AIM, and for whatever reason, aspirin pulls as essentially Excedrin. And specifically EMS charts, but I've caught a couple other vendors as well. The entire crew isn't pulling over, so only one provider is pulling over into the state bridge.
I've seen, I see the assessment in pretty much any, there's no like, won't play people, but I put in so many random places. It's incredibly hard to find. One of the frustrating things I have is they put the assessment in the reassessment or events thing, especially in EMS charts, CFC. So they say, you know, they time every intervention, but then their first intervention is their assessment. And it's infuriating because I agree, like I'm
It's
going
really
right there
frustrating.
trying to find it. And it's just a nightmare trying to locate these things. So,
Yeah.
I don't know.
Sometimes it's an issue between discrete data fields and text data fields. Some providers will narrate their assessment and not check the boxes. And if the bridge, I'm not sure what that looks like, if it's only pulling over the discrete data, which is the check boxes, then the assessment would not be transitioning into the data. So it may also be behoove people to maybe to request, if you have a handful of charts from a particular agency that are missing assessments, request those records and compare them. Does that make sense?
Yes. Yes. So May, I finished Thursday. So for May, we pulled 81 charts, 49 were from Mountain Lakes and 32 were from the North Country. And this is where we're at. Assessments are looking a little better. This month was the first repeat month for all of the higher call volume agencies. And I did notice that a few of the agencies who had terrible assessments in January had better assessments this month. So.
Well, one thing we are noticing kind of globally is narratives are horrible.
Yes. That's
They're either full of grammatical errors or misspelled words and, or just extremely lacking, like 2-3 sentences for a cardiac arrest. And that's not acceptable. I've been pulled into court for charts before for calls that happened way before I got pulled into court. And a good narrative is what probably saved my butt. Or saved the person who was on a comp case and they caught him. So we just need to remember that these are legal documents and a lawyer is gonna look at a chart and if it's not well written, they're gonna shred you in court. And we are building a lecture for our LMS, basically called the Good, Bad, and Ugly, an EPCR overview of, and we're gonna use actual narratives from charts and break it down to, like, this is how you write a good chart that is gonna paint the story of what patient care you administered, but is also gonna keep you legally out of trouble.
Jonathan?
Yes.
So this is Patty. So one of the things that maybe part of the problem is it needs to be stressed that the narrative is what's important for your coders, and that's really where our billing comes from, where they do not necessarily look at the drop down boxes. So that might be one of the problems. So you're like duplicating effort a little bit by doing just your narrative and your drop down boxes. The drop down boxes, it should be stressed to the agencies as that's what the state pulls out, and not necessarily the narratives, I don't believe. So there's multiple probably components to what your issue is.
Yeah. And we're trying our damnedest to get to the bottom and make it better. We have a unique opportunity too, because we get to see 2 regions. So we have a large swath of the state that we get to look at. And it's not isolated as a Mountain Lakes problem. It's not isolated as a North Country problem. It is a global problem.
It's an EMR. It's an electronic medical record. We see it, all the time in even hospital-based electronic records. The data is collected now in drop boxes and check boxes, and the assessments are frankly, scary on all fronts. It's just navigating how to educate the providers, whether they're hospital-based or EMS-based, on what boxes to check to make the story make sense. And it really is focused education. It's not something that's, inherently known to most people regularly.
I agree. So EMS agency operating or ALS operating authority renewals are here listed on the screen. I will turn that back over to you, Dr. Bombard.
Actually, I'm going to consult Dr. Pond because he's been pretty opinionated about what he wants to see before we do these renewals. You wanted some data, Dr. Pond, before we do the renewals?
Want some data? I'm not following you, Tiff.
So in the past, many meetings ago, we would cull through data regarding each of these agencies before we approved them. That went slowly away, which I was not opposed to, honestly, because I felt like that was really the discretion of the agency medical director, but it sounded like you really wanted that back. So if you'd let us know which information you want about these agencies to be presented, and then we can rip through them hopefully.
Tiffany, we already discussed this in the meeting in the past and agreed on, I don't know, several criteria. I didn't even necessarily agree with those, but we came up with criteria to look at before these renewals. So that should be in the minutes somewhere.
And I think that's what we are sending now.
But we're sending it, we're not presenting it, correct?
Correct.
Excellent.
You're sending
I
it
think
out.
that's,
Yeah.
You're emailing them.
Yep, it's in the file or the link that you get for the files for everything. It should all be in there.
okay.
Is
Lovely.
it,
We're still okay with that, Michael? If they're sending it to the agency medical director, we don't need to discuss it here. We can just approve.
I haven't seen it.
Did that go?
Yeah, there's data, the data, yeah.
Is it in a file? Is it in one of the files or is it?
I think it's called agency data reports.
It's in the May folder, it's not in the subfolder.
Should be in the May folder, then,
So while we're looking for those, so I would suggest if this is data that the committee is going to use to approve or not approve, since there's a voting process, then it should be something we should all be able to see and discuss while we actually approve these agencies. Otherwise, we just take the medical director's word and his, and his, as he puts these agencies up for approval, then we just assume that the medical director has viewed and we're good to go. So I'm happy either way, but I guess the group can decide how we do it.
I'd like to see the data too.
I
think-
thought we already decided this, that the basic information on each agency would be presented when we went to the group, when we went to approve.
Yep, that's how we did it previously. I will fully support that. I think that's right. And we used to look, I mean, I don't remember all the areas that we viewed, but certainly looking at their staffing plans, their drop calls, response rates, those were some of the typical things we looked at, right?
Yes, yes. And I asked Zach to go back and find this. Zach, you've been here since we were doing this, and it's like we're asking for, I don't know, something impossible.
yeah, there was an email that was sent out after the last meeting and nobody really responded to it. Dr. Williams sent a list of items that he wanted that, and that was sent out to everybody along with multiple topics, along with the new data report that we started last month, which I ran the same thing since I didn't hear back. So that was in there again for this past meeting. If you go on the meeting materials, instead of clicking on each individual agency, there's a folder called agency data reports, and they're just all in that folder.
I don't see that.
Where is that? I went through this. I don't see that.
In the Google Drive.
No, I'm looking in the Google Drive.
I don't see it either.
It's a link in the email as well.
I linked to the email. That's how I got to this.
Once you click May, here, I can.
Yep. Screen share.
Look, I vote right now, or not vote, but I suggest that just give us a way to look at that. We've got a lot to discuss today. It's already an hour into the meeting. Let's approve what we can approve here and move on.
Yeah, I mean, I think you should see the names of the medical directors there. To me, I would think of this as a forwarded motion from them. So in other words, they have already reviewed that. This committee certainly should have access, and I do see the file that Zach sent to confirm it. But if it's a forwarded motion, really what that means is that medical director is comfortable with the data that was submitted. And so if their name is there, that in my mind should indicate they said yes, and it's a forwarded motion that we can then take from there.
So it seems to me that there are two different thoughts on this. I think one should be put forward as a motion maybe and voted on. And if that doesn't pass, then maybe refer back to the other one. But we talk about this every
Yeah.
meeting.
Well, can you put that list back up again of the ones to be approved? And let's take the first batch, which were the 2-year renewals. So I see a medical director named to each of those. Is there an attestation that they would either agree to or have done that they've reviewed everything and they're doing this as a forwarded motion for us to vote on?
The medical director form that the medical directors have to sign as part of the process, yes. And that's what happened is back in 2019, it switched and the medical director form became, like we're talking about, the forwarded motion from that medical director for then just approval by the REMAC. And that's kind of when the data and stuff like that kind of stopped being a thing, is when it went to more of just the forwarded motion from the individual medical directors.
And
No,
what
we
we,
don't think that's true. We did look, the only way you can have checks and balances on this is for the other medical directors to be able to look at that data. Otherwise, there's no check and balance here.
Yeah, Mike, I don't disagree. I guess I'm just saying for purposes of taking these as a batch, that information should be provided. I do see it within the zip drive that was provided, but the medical director attests to that they reviewed that and are comfortable with it. And then we could always pull some out. And that's generally how these, kind of batch forwarded motions go if you have any questions, and the remainder can then be taken as a batch.
Yeah, okay. I didn't see this data thing, so I think we should just move on and get these voted through.
and what we can do moving forward to, just to make the process a little easier, is instead of sending it, we'll include it with the entire packet that goes out to everybody, but we can also send these data reports and the attestation in a completely separate email to everybody. So it's all in one place and you're not having to dig and look and find it.
That'd be great, because I've looked through it several times and I'm still not finding it in the Google Drive.
And I gotta tell you, that little attestation comes to me half the time without anything else with it at all from the service. So I think that's a good idea. Let's move on. Let's move on and get these voted through.
So just
Okay.
moving forward, just not to interrupt one more time. So just moving forward, we're gonna go with what Mr. Broderick said, Dr. Broderick said, as well as what Jonathan said, making it a little bit easier to find this data so that when the doctors come, they feel comfortable voting on this, correct?
Correct.
Okay, so that should be reflected in the minutes really clearly.
Look, and furthermore, so when an agency comes to us for renewal of this data, they need to come with this data in hand as well. So we're not just signing their nondescript paperwork, right? If we are forwarding the motion for approval, it implies that we've done due diligence and we need access to that data when the agency comes to us with approval. So once we've decided, or I think we have, on what the specific elements are that we need to review, the agency then is responsible for providing the medical director with that specific data so we can look at it and approve it or bring it forward for further discussion because we have some concerns.
I agree. Can we move on now?
Can.
Well, if all those from that previous list were attested by the medical director, I'll second that forwarded motion to approve those 2-year renewals.
I just want to make one amendment to it. We've got West Glens Falls listed under my name. It's actually Dr. Williams' agency.
Yeah, that's a separate thing we got to talk about. Dr.
okay.
Dr. Mulvey is not here. She's got a family emergency. I did talk to her before the meeting. She's comfortable with Moira and Westport.
And I was just texting with Dr. Cardos, who is comfortable with Lake George. So I think we can approve these as a group. Who was that second in motion? Was that Dr. Broderick or Dr. Gurley?
Broderick.
That was me, Broderick.
Any opposed at this point? Hearing none opposed, so moved. And the 3-month extensions.
Was that from prior TIF? I didn't make the January meeting, so I don't remember.
So they were extensions from the last meeting because the medical directors wanted to be at the meetings. So that's.
Yeah,
why.
if the medical director isn't at the meeting, they can't get approved. So I vote that the 3 months extensions go through. And I'm representing Dr. Mulvey.
All right, any opposed? Hearing none, so moved.
Okay, back to the presentation. I just have 2 more things that I'm just gonna talk to you guys about really quick, and then we will move on. I promise I will talk super quick. Okay, back.
Natalie?
So we have a new initiative that we are starting to do out of our Watertown office, which is called the Matters program. So Matters facilitates rapid referrals for individuals with substance use disorder, connecting the participants with referral sites, receiving treatment and peer-to-peer support from agencies, pharmacies. They get there's tons of services that are offered from it. Can you move that box so I can actually see the screen? Thanks. Perfect. So the individuals are connected to an outpatient treatment organization of their choice and are seen as little as 24 hours later. And EMS agencies can participate by either becoming a referral site or they can participate in a Leave Behind program, which we are spearheading out of our office. We are a referral site, so we get the notification when someone has actually signed up for help, but it connects them with telemedicine capabilities. I have talked to Dr. Bombard about this, including the next part. So we do offer free naloxone to our first responder agencies. It was previously just for the Jefferson, Lewis, St. Lawrence County agencies because the North Country's medical director is the overseer of that program. But we have talked to her and I've spoken with Dr. Bombard to expand that into the Mountain Lakes region. So if there are any agencies that want free Narcan,
Nasal Narcan.
Nasal Narcan. Spree nasal Narcan.
4 milligrams or 8?
4. It's 4. We don't want a waterboard. So it's 4 milligrams nasal Narcan. We are happy to provide that to you. We will make arrangements to get it to you. We will either mail it to you. And if you want to participate in the naloxone Leave Behind program through Matters, that's actually a little package that comes with 4 milligrams to 8 milligrams total of naloxone, 2 doses. It comes with fentanyl strips and xylazine test
And
strips.
it comes with that little card.
Yeah.
for resources.
And it comes with a resources telemedicine card that they can scan a QR code. A lot of our agencies on that side are opting with the Leave Behind program because they don't have to actually talk to the patient. They can just leave it sitting on the kitchen counter when they leave. So if any agencies would like to participate in that, or your agencies would as their medical directors, please send them our way. We are more than happy to do this. Any questions for the program agency? Anything? I hope not, and we'll move on.
Okay. QAQI report. Scott is here. You want to do?
No, if anything, we've met once since our last medical director training, trying to get organized. So. And we'll invite you to the next meeting.
Thank you.
As we talk.
Storm?
Oh, we haven't met. We are still struggling with getting ourselves restructured and getting ourselves where we want to be, but we're not there yet.
Where's ECH?
It's gonna take us time.
Patty knows.
Patty does? Patty, you still on?
Yes, I'm sorry, I was talking to a doctor. Can I say it to me again, please?
QAQI from ECH.
Oh, I'm sorry. Is Lisa there?
I didn't see her, but
No.
Okay, so we've been doing really, really good. The agencies that were coming over to us, such as Saranac Lake and those guys are, Dr. Pond is working out a plan for them, and I don't know if he wants to speak to that or not. But our agencies are doing pretty well. Had some pretty significant calls recently. Our QAQI was last month, I think it was, and I keep forgetting that we need to send a report. We get so involved in getting it done and whatnot, and I keep forgetting to send a report. But the agencies are doing well, and no real things are sticking out. We are going to go forward with the new protocols, the changes that are coming out, and starting this month, start highlighting some of those changes so that they're aware during our CME events. But other than that, we seem to be doing really, really well. And I'll be more, I think Lisa does a report. At the very least, we can send you the PowerPoint as to what's going on.
awesome. Thank you. Glens Falls.
We had, we've had some QA meetings recently. No major issues, just we've been working, changing our stroke protocol just to improve flow through the department, but that's kind of our site-specific stuff. Otherwise, smoothly.
Cool. I think that's everybody, even though it's not the whole, there's more stuff, more places on the list, but I don't think that we're actually doing QA there yet. Okay. So there's a note of it. We need to choose a regional study for this year. Anybody have any suggestions?
What's the purpose of the study?
We could do Dr. Katz's QAQI, North Country.
Oh, sorry. My apologies, Ben.
And then we have to do Tri-Lakes.
Well, but there really isn't a Tri-Lakes, and that's why we're not doing it, but that's okay. All right,
No,
go ahead,
but we
Ben.
have a plan, so I think we
Yeah,
should.
let's hear the plan.
Well, are we doing North Country get done or Glens Falls?
Glens Falls is done. Dr. Katz, please go ahead. Ben says his audio isn't working. Okay, we'll put you
Okay.
off for a minute.
I'll do mine in the meantime. So Tri-Lakes hasn't had a QA program for 5 to 10 years. There's been very little input, well, no input at all from Adirondack Health, the regional hospital, general hospital. We have to discuss, they need to have a representative here, which may be Fred now for the hospital, but that's to be decided. I took on a bunch, well, not a bunch, 3 ambulances out of 5 that didn't have medical directors, service medical directors since our last meeting. But I don't want to continue with those ad infinitum. So Tiffany and Fred Laporte and I met, and Fred has become the Adirondack Health ED director. We kind of talked about putting the Tri-Lakes Quality Assurance Plan back under the ED He is working with the hospital to appoint somebody to oversee this, and he's agreed to take responsibility in the next few months and or appoint some other doc to do this. So hopefully we are getting the Tri-Lakes quality assurance back under control, under our supervision, which is required by the law. That's what Patty was referring to, because I was moving those ambulances there. But it looks like we now have a active physician from Adirondack Health. So hopefully we'll get this kind of repositioned in the next few months before our next meeting. Any questions?
All right, thanks, Dr. Pond. Any thoughts on a regional study? That might be important to anyone.
Well, what do we, this is just a year-long study where we looked at one item or one intervention.
Yeah, so, we've talked about doing this at a few meetings where we're at least looking at something. And it doesn't have to be a million things and it doesn't have to be a big thing, but it's something that we're looking at regionally from each of our QA groups. To see, what, maybe your providers are doing something way better than mine are, and maybe I can learn from you, right? That sort of approach.
Is this a required thing that somebody's dropped on us, or where's this coming from?
This is coming from us ourselves. We've talked about this at multiple meetings in the past.
Yes,
It's a state requirement.
yes, it's part of the deliverables.
It's also a state
It's a
requirement.
state requirement, right? Yeah, I do remember that.
Well, let's pick something that's simple and we can actually accomplish. I don't have any good idea though.
Do you have any examples of other regions and what they do, or?
We did a ketamine administration study a couple of years ago in North Country. What was the last one we did?
Does it have,
Oh, go
does
ahead.
it, sorry, does it have to be clinical? Does it have to be like patient care directed? Could the focus be, this performance improvement in relationship to documentation, improved documentation around a specific, like diagnosis? Like improved documentation around chest pain, or, like narrow your field.
I would say yes. It's always been aspirational and rarely does it result in anything meaningful. So if you think, Tammy, this would be something that would potentially benefit, then I think it's really up to us to decide.
I would love to see us look at IV fluids and trauma.
IV fluids and what?
Oh, now you're speaking my language.
I would like to see how much IV fluid we're giving in response to trauma. And I'd like to look at like what, how much IV fluid are we giving for what blood pressure parameters in trauma? How often are we overshooting?
A local QI did that somewhere recently, or like within the last couple of years. They reviewed their.
It does sound kind of familiar.
Yeah.
We've had the idea of progressive hypotension for a decade, and yet our protocols say that we can give up to 2 liters of IV crystalloid in the face of trauma. Are we doing that? Because that's scary if we are.
That would be a no. I'm not at CVPH anymore reviewing regional. I'm at Albany Med, but in my past experience, and current, IV fluids are, well, especially in the North Country, not given as much as we think they are.
Okay, well, look, let's just study that then. Tiffany, what do you want to do? Just look at all traumas and how much fluids are given?
Yeah, and I can talk with Zach and John about what we can achieve there practically, but it would be interesting to see what what blood pressures are we treating.
Okay.
And I would
Allowing for
include transport
I
time
don't
as
know if
well.
that data.
I'll make the
Include-
motion that Tiffany talks with our folks and see what's practical to pull out on fluids and trauma.
They actually changed the protocol too. It's not 2 liters.
It's now 1.
It's 1 liter then 500 an hour if it's compensated shock. If it's decompensated, it's a 500 bolus.
Is there a second for the motion?
Yeah, I'll second.
5 to a max of 2 liters.
Any further discussion? Any opposed? It passes. Our medical report. Do we, I saw Colleen here.
I forgot to send it, my apologies, but I
That's okay.
did
Give us a
bring
few.
EMS week cupcakes.
Very nice. Do we have any feedback for our providers from LifeNet in general?
No, I think the one thing that we would like to be is more included when we do debriefs, CQIs for any patients that we bring into the, to the hospitals.
Okay.
That would be very, very helpful for our team to be included in those CQIs and or debriefs.
Could you guys hear her? Okay,
Yes.
perfect. Dr. Daly, do you happen to have a report from HealthNet? I know that you're not their direct medical director, but you're closer to that team than I am. So what we've allowed for is some time for air medical reports in case that there's some feedback for us, for our providers that we would not get by any other means. Did Dr. George happen to hand anything over to you regarding that?
No, he did not, but I'm unsure, not to put them on the spot at all, but I don't know if Leslie or Danielle has that information either. If not, I can talk to Doug and get that to you guys.
Tiff, what was the question? Feedback?
Sorry. So what we have started to do is just to allow a couple of minutes during this meeting for our air medical services to give us any feedback that they feel might be important for our providers. And it just opens this forum for you guys and opens that dialogue, because sometimes that's not the easiest communication. Sorry.
Yeah, no, I appreciate that. I heard Colleen answer. I just want to make sure I understood. I don't know. I don't have anything specific, not something Doug and I had specifically chatted about, but we can ensure we have that conversation ahead of the next meeting.
You don't need to produce anything for these meetings.
If there's something to bring your direction, there might not even be, so.
Yeah, sometimes there's not going to be, and that's fine. You don't need to produce something just because.
Thank you.
Okay.
I have a question for them, if I might.
Please.
Is there any progress or final decision on Lucas devices on the ships?
Right, so actually we just did a training with Lucas Device with Westport Fire Department. And it went very well. Looked at some of the hurdles that we have to, especially depending upon the airframe. Because of the height of the Lucas device and getting it into the clamshell, the back of 713's aircraft. But we do carry them. We are, to my understanding, we are signed off with utilizing the Lucas device. So at this point, yeah.
So you guys are carrying.
We aren't carrying it. We do not have one at 713. We have one at our Watertown base. So we will lease them. So for instance, I believe Mariah had the Lucas, so we can transport that device in our aircraft because we are signed off for them.
So all aircraft in our region can accept a Lucas device.
Yes, it can accept a Lucas device.
And Tiff, from.
Yeah, that's exactly right. I'm sorry?
No, Colleen, it's Leslie. I didn't mean to cut you off. I was just going to say HealthNet has capital planning in progress for Lucas devices. Just because of the weight, we don't necessarily intend to always carry it once we have it, but it would be available to take and respond with if needed in the helicopter that's based in Burlington.
That's exactly what we're following too.
Perfect.
Okay. Under what circumstances do you guys anticipate using a Lucas in the air? Just out of curiosity.
If it was an unstable cardiac arrest.
So somebody with like intermittent ROSC sort
Yeah.
of thing?
Yeah.
Or a super hypothermic person that we need to rewarm before
I can get you our
disposition?
or our protocol for
No,
that.
that's
Yeah.
sort of intuitive. I just wondered if you were gonna say something that wouldn't have popped to mind.
If that's our same intent.
Perfect. All right, education course sponsor reports. Clinton.
So, yeah, so Clinton is finishing up. The basic course is finished. They tested on the 11th. They were starting a summer course. They're starting a summer course. They have enough people to run it. So we will start that course. It will start evenings and then move to a day course. So we can accomplish and be finished by August 1st. Is our goal. And then we'll run our usual courses in the fall, which is basic, original, and refresher, and then an AEMT course.
Are you kidding?
We did this. We did it.
I'll do ECH. As far as the paramedic programs is concerned, they have about a year to go. They're gonna start their clinicals in just the next couple of weeks. The class is going strong with its new course director, Josh Ledoux, who will be here in future meetings, but as a full desk right at the moment today. North Country.
We ran about 125 people through original training last year. About 40 of them were AMTs, the rest were EMTs. So it was a pretty busy year, about 50 more than the prior year. And we're hoping to sustain it. We're shooting for around 150 some upcoming year. So it's been pretty active.
Yeah.
Mountain Lakes. Anything from Hamilton or Queensbury?
Nothing that wasn't already reported.
Okay, beautiful. All right. New business, we have transport guidelines, some health net ones and some Malone ones. I did just text back and forth with one of the senior CMAC reps who confirmed for me what I had said to Ed. I was pretty forthright with him, but then I had a little paranoia, right? What happened? So I did a little teleconsult there, and yes, that was correct. The CMAC does not need to approve interfacility transport protocols. And in fact, even having the REMAC approve it is sort of a gray area, apparently. As long as the service medical director approves them, that is the important bit. However, we traditionally as a REMAC have approved these or not. We've at least had an opportunity to review them. So you've seen the health net transport guidelines, yes? There were 6 of them.
Yeah, to me, the central question is this: do they have real-time online medical control? Which I believe UVM does, but you can correct me if I'm wrong. In which case, that to me is good, and then it becomes less of an issue. If it's interfacility transport that relies on the Signal 600 process, so in other words, they don't have direct medical control, then I think it becomes different, because then it's like, are they consistent with our formulary and other things that are internal? So if you do pick up the phone in ED, you at least have some idea and it's consistent with other protocols. So I mean, that's how I just largely look at these things as it relates to that. So I'll start with the UVM. Do they have, like they used to, and I still think they do, in which case I would make a motion to approve and not be concerned about it.
UVM has actually fantastic medical control, and Danielle, I'll let you address this too, but I get excited about it because it's really neat. So they have sort of a football, like they have a phone that goes to a medical control doc that their job is to do medical control for the day, night, 24, whatever, for the shift. And sometimes they're on shift and sometimes they're home, but regardless, they are an EMS trained doc that covers that job. So it's really, they're really integral to their interfacility program. Danielle, do better than me. Go for it.
No, that was perfect. There's also backups too. So even if that person doesn't answer the phone, then there's the next person. Ideally, the person on call for medical direction is not actually working clinically, so that they're even more apt to be able to address any concerns in real time. And so there's even been a third line if they can't get a hold of medical direction. So they are intimately involved, EMS trained, so they know in and out what the capabilities of the teams are.
Okay, with that, I'd make a motion to approve. Thank you.
Do I hear a second? Anybody want a second?
John, you're approving the UVM protocols. Is that what we're talking about now?
Yeah, just with confirmation that they have real-time medical control. So I think that really is, to me, the distinction here.
Okay, I'll second that.
Any further discussion? All in favor? Might as well do this here.
Aye.
Aye.
Any opposed? Okay, motion passes. Okay, Malone transport guidelines. There are a whole bunch of these, there are 12. And these are for Akwesasne, Malone EMS, and Northern EMS. These were written in direct response to needs from the ED. As you saw, I sent out an additional explanatory email about them, which hopefully has allayed any concerns, or at least most concerns about them. One of the things that was brought to me by my boss as a concern that I thought was important to underscore is that writing these protocols does not mean that we're going to leave a paramedic in the back alone with an unstable patient, right? That's something that should never happen. So either we need to have 2 aptly trained paramedics, or we have to have a paramedic RT team or a paramedic RN team as applicable. And the rest of it you read. Madison, you have a question?
Yeah, actually, it was
Right.
actually Dr. Ponkingo. My question was actually about just like in terms of the resources. And I think one of my biggest concern was having, like if somebody on an ESMO drip for aortic dissection, having one provider in the back when things become unstable is, I feel like, not fair for the patient, not fair for the crews at hand, sending doc, basically.
Agreed, absolutely. Oops, you're off frozen there.
I just want to put it out there. I don't understand why we're getting multiple sets of protocols. And as I looked into this since Tiff, you sent these out, which I think are very simple and very good. I just don't know why as a region we're going to have multiple protocols for different agencies when we have very few people to work on ambulances. And to me, it doesn't make sense for them to have different protocols for different workplaces. I'm looking at this from the 50,000 foot level, that we should just have one set of protocols for the region. And we've now got UVM protocols that are partially accepted, and we've got these protocols that are on the table. My feeling is that we should have one set of protocols for the region, not multiple sets. I checked, Glens Falls has other things they deal with. We've got Lamoille ambulance that's out there. We don't have protocols for them. I just think this should all be in one. We should have one set of regional protocols. And, I sent out an email to put this to committee with the interfacility transport agencies and let them sort it out and bring us back protocols for either the region or whatever. These could be, there could be exceptions to them, but I think that would be limited based on, limitations of a region or something. So that's my 2 cents on this.
Yeah, and to clarify between protocols, there's interfacility and then there's specialty care. So I think of interfacility more as fairly standard, and I think if you said 2 paramedics in the back, which or paramedic RN, but 2 paramedics in critical care, we have now removed from that. I think that makes perfectly good sense. But I recall we used to think of them differently, ICT and SCT, with SCT requiring additional training that the medical director or designee would subsequently do, and then attest to, and then usually then go ahead and forward that. So just out of curiosity, is this Malone, would you, it says IFT, is there any additional training that's necessary for that, or this is, it looks pretty standard to me? And then of course the medical physician or the physician transferring would have to write the specific orders, and that would be within the parameters of this, correct?
Correct. So these are all my agencies. My plan is to do the training myself. And these are paramedics that I know well, and so I'm pretty comfortable with what their capabilities are and are not. The protocols were written by me in response to situations that we were having trouble getting patients out of the ED because we did not have an RN or an RT available to help with the transfer. And so this would train our paramedics to either be part of an RN, RT paramedic team, or to take these patients with 2 paramedics if needed, or if the patient was super stable, they could take them by themselves, obviously. But this was, again, a direct extension by me of their training that would be documented and watched by me. So that was also delineated in that email that I sent out to you guys this week. So that was something that you saw before as well, obviously.
Okay, so that'd probably be more specialty care, being that there's some additional training that you or a designee are going to do, just to ensure that. And it's going to be at a minimum 2 paramedics, or a paramedic respiratory therapist and a paramedic and nurse.
And situationally, obviously, some of these patients, you know, if it's a straight up non-STEMI heparin drip patient and that's the only protocol that they're using, and the patient is super stable, obviously they don't need 6 people in the back of the ambulance, right? But as appropriate, if the patient is unstable, clearly we don't want one provider alone in the back of the ambulance.
Yeah, again, SCT. Yep. Okay. I saw a hand up, couple.
I can see Dr. Daly. Was there somebody else? Well, let's shoot at Dr. Daly because that's who I can see.
Yeah, I'm sorry I froze before. Knock on wood, it won't happen again. Yeah, and you know, for SCT, often these crews have specialty certifications. Like they have the, like not the EMTCC, but like a critical care certification, and the to kind of take these very sick, unstable patients that require these kind of critical care interventions, whatever that may be. I don't quite understand how in the kind of IFT realm here on the New York side, like, are we kind of extending the scope too much? Is this like scope creep? Are we putting these paramedics in these kind of difficult situations? Because, you know, I see that the medications we give and is somewhat simple. My concern is that the complexity of these patients may be too much for the crews with their paramedic training.
I share that concern because I've got an ambulance now that has 500 transports and hasn't been in service at all on these kind of drugs that have been on their rig. There's hands up.
Go ahead.
It's Tammy again. My question has to do with the training and the formality of the process. So, you know, God forbid something happened to you, Tiff, and you weren't in that role that you're currently in. Would your successor have guidelines for ensuring that the training is sufficient for the new people coming in or to renew?
That's a good question. I had not thought about a successor. but certainly I can leave a legacy of what training we have. That's easy enough to do. Madison, or Patty, sorry, and then we'll come back to Madison.
So are these just agencies, or what agencies are you looking to do this with? Just EMT of CBPH, or are your other agencies up there? Would that mean Saranac Lake could go in and take a transfer? What are you looking at for what agencies, I guess, is one of my biggest questions.
So this was written, these protocols were written by me for my 3 agencies only. And they are Akwesasne, Malone EMS, and Northern EMS coming out of Malone. I will be responsible for these and for their training and for their ongoing training. And agree, Tammy, I'll leave a legacy of this because I share your concern now that you brought it to me. Thank you.
So will this open the door to other agencies who want, like the Saranac Lakes or UVM out of E-Town? How big is this gonna get? And I don't know if every medical director is gonna, you know what I'm saying? How big, like, I just don't want to lose like control. If this is just like 3 agencies, you know, and I know up there in the North Country particularly, there's not necessarily a lot of resources, particularly at the hospital level, I'm thinking. But is it just, I mean, is it going to get bigger? And then we lose control of that part, that piece, the training, are we certifying these people at a specialty level, that type of thing?
So we're not certifying anybody to do anything. These protocols were written for my 3 agencies and my 3 agencies only. If, say, let's say Dr. Mulvey says, hey, I really like some of these protocols and wants to adopt them, she is free to do so, but she's again going to need to be responsible for the ongoing training of her own providers and to be able to document that training. And, you know, if one of the other medical directors wants to do the same, obviously, you know, this is open source, open content. But these are not offered to the region as a whole, right? These are offered to my 3 agencies only, for whom they were written, and which I will be supervising those agencies.
Right, and I think that's really the issue. I used to do this with Empire when they existed. These are market forces, market medical forces that we're not going to be able to stop. We can only be part of it and see if there's some ability to be able to understand, because these patients will get transferred. They have to get transferred. The hospitals will not be able to supply nurses or others to do this. And so it's left upon the EMS system to ultimately move these patients to a higher level of care. So that's just the market forces that really we're not going to be able to control. So the best thing we can try to do is get our arms around it. But to your point, Patty, I think just understanding who's doing it and what medical director is providing the training with some minimum annual, retraining and some competencies, I think is important, and that's probably the best we're going to do as a group with no teeth and no direct budget.
So I have a question. So we're writing them for 3 agencies with the opportunity for other agencies to grab onto them and use them, which would make sense, because it would not make any sense if we have multiple sets of protocols out there, because we had this with basic and advanced life support protocols at the state level. We had this big whole mix and we gradually got it all together. And I'd like to see us do the same thing. If we're going to do it for 3 agencies in the North Country, who else in this medical director group wants to jump on and say, can we set this up for these specific agencies across the board for the region, which might be more helpful to do it, because then it would not be just limited training, but maybe we could build something region-wide because people want to learn and they want to do better at their job, particularly the transport world, I think, better than some of the other stuff. So maybe that's the answer as opposed to just having you build yours and you build yours and somebody else build something
I think the
else.
problem is there is no real way to, like, there are, the New York State protocols are set by the state and
Right.
where these fall into a gray area, right? They don't come from the CMAC. They're at the agency
Right.
level. So you could certainly set something up like that. It would be up to each medical director of each agency to adopt it. So,
Right.
so
Who's-
Tip made her own.
Who's talking?
Dr. Williams.
Okay.
So Tip has made her own protocols for her own agency.
So are we gonna have, any medical director can do any protocols for their ambulances anywhere in the region? We could end up with 10 sets of protocols.
Because they're unregulated, that's how I understand it. Every agency, every medical director could have their own interfacility transport protocols because they're unregulated on a large scale. The CMAC doesn't seem to be interested in regulating them. So we absolutely could fall into the pit of having 30 different protocols for 30 different agencies because there's no state, region, whatever guidance on what to do.
I think common sense dictates that that's not a good idea. So I again would say we should have regional protocols for our 5 counties, not 30 different sets of protocols by every single service medical director.
Do we have the ability to enforce that? Like, because, I mean.
We don't have to approve these protocols. We certainly have the ability to do that.
I thought you said the gray area REMAC approval of these protocols
Yeah.
was a gray area.
That's what I was just told is that actually REMAC approval is a gray area.
Yeah.
We're not sure that.
We got a
REMAC
state person, we have a state person here that represents EMS. What's the story with this at the REMAC level? Where's our state guy?
Ed
He
had
signed
that-
off.
Ed, or I think Melissa or, okay.
We've traditionally looked at these as a REMAC.
Yeah.
Most recently, so there were several protocols for Malone. They were like 2 years ago, maybe Dr. St. Jean brought to us, and we all sort of scratched our heads and said, well, those are odd medications to want, but if that's what you're needing, then there's no reason that, as long as you're gonna train your people, then we were okay with that. That was 2 or 3 years ago, and I think that's, other than the Health Net protocols, I think that's the last encounter we've had with this.
I would like the protocols. I just, we have, Doug and I both have a number of agencies volunteering to do transports to Glens Falls because of a lack of available transport services. So we certainly would put these protocols to use, and I absolutely would like, some standardized set. I have no opposition to it. The only point I was making was that we don't have any way to enforce those for every agency. Because, I don't even know, I don't know what our power of review or refusal is. So if we made a general protocol for the region, I would use it. I'm sure plenty of people would. But we couldn't, I don't think we would be in a position to,
You as the medical director put it.
Yeah.
You as the medical. So you as the
Because I'm
medical
buying
director,
into.
me as the medical director for agencies, could certainly enforce that protocol and say, you don't use anything above or beyond or.
Right,
You do.
but any medical director who doesn't buy into the whole process or disagrees with our protocols, we couldn't force them or disincentivize them or punish them if they don't use the protocol. So they would be completely voluntary from a medical director standpoint.
They
We have developed.
They would be at risk, actually, if we make regional protocols that are agreed upon by this group and somebody decides to go outside that or not use that, there's a medical legal risk for that. you look, if we want to make these universal protocols for the mountain lakes across the 5 counties, I'm all good with that. But I'm not good with every medical director coming up with whatever the hell they think they want, or whatever drugs they think they can use, or whatever they're going to teach paramedics. I agree with Dr. Daly. We are pushing paramedics way above where they should be on drugs. I question, and I can tell you that there's ambulances taking drugs on ambulances that they haven't been trained on. That's a fact.
I'm not gonna argue with that. I think that's, yeah, I would be, as more and more agencies are gonna start doing these transports because of lack of resources in our area. I mean, Dr. Cass, Dr. Drilling, we see this at our hospital. We're relying on more and more agencies, and, I agree, unless we have some standardized protocol or something universal, it's gonna get messy, and, these paramedics are doing stuff that they're not trained for. So I fully support a generalized guideline set of protocols.
I'm going to make the motion that this goes to a subcommittee of the ambulances that are doing the bulk of the transfers in our region with their service medical directors, and plus minus a representative from those ambulances, and decide our regional protocols.
Dr. Daly, I think.
For interfacility transports.
Michael, I'm going to ask you to hold your motion until the end of discussion, and then you're more than welcome to make any motion.
No, that's actually not the way that's not the way the Robert's Rules of Order work. This is on the floor now. You can have discussion after the motion.
But we weren't done with the discussion we had.
It doesn't matter. I've made a motion. If it doesn't get seconded, it can die.
Do I hear a second?
I actually do agree with Mike. I think this should be subcommittee. I don't think we're going to make a decision today. We can have a lot of discussion about the positives and benefits, but it seems like the overwhelming consensus is there's high risk of having one-off protocols, and having a one-off protocol approved just so we can get it done, while the rest of us are saying, gosh, that seems high risk without standardization, and hey, this seems like a lot of liability, does not seem like a good idea. So I think a subcommittee and tabling this for another meeting would be more productive.
So you've seconded the motion?
That's affirmative.
Now you can have your discussion, Tiff.
Any discussion?
Didn't we used to have kind of
Yes, we did. Yes, we did,
protocols?
John.
It's
Yes, we
part of
did.
the collaborative practice, the collaborative protocol group that was very large. What happened to those? I mean, I'm not as involved in EMS as I used to be perfectly honest with you, but I worked on those and I thought we had those.
They disappeared like a decade ago. I think it was under your rule.
Yeah, I remember that.
The
Okay.
collaborative protocol group still exists and functions on a monthly basis. They create 911 protocols. They do not create interfacility protocols.
We did secondary. I do remember.
No,
doing-
John's
not.
right. John's right. We did have interfacility protocols.
Yeah, and the purpose was that because frequently they would cross REMACs, and so we wanted some standardization. So that was the reason behind it.
They've disappeared in our black hole of file cabinet. Is there any
Dr.
more?
Daly,
Yeah.
Dr.
Any more?
Daly has had her hand up for quite some time now. May we please hear?
I'm so sorry. I did not realize it was still up. It doesn't look up on my end. I'm so sorry. I have nothing to add besides of what I already discussed, specifically my concerns with just, scope creep and putting these paramedics in difficult situations kind of outside of their education. And I really think, I know we are not like a national register state, But just, I do respect that, that people who do take these critical patients do have a critical care certification behind them.
Thank you. Dr. Pond, did you have something further, please?
No, I think if there's no more discussion, I'm going to call the vote.
Is there any further discussion? Any in favor? All in favor, sorry.
All in favor. We're making a subcommittee.
Zach, can you repeat Dr. Pond's motion for us, please?
Yeah, for the most part, it's motion for the subcommittee of ambulances and service medical directors to form protocols for interfacility transports.
With a representative potentially from the ambulance itself to sit on the committee as well.
And we can help facilitate those meetings and give a platform for them.
And so.
I will caution you that, we can create a regional protocol and that's certainly doable. But again, it's each service medical director that's going to be ultimately responsible for that protocol within their service. You understand that this isn't going to be a collective responsibility as a region for these protocols. There's still going to be the responsibility of the agency medical director. That's not my rule. That's how the world is.
So these will be guidelines rather than protocols, which we would encourage people to adopt in their agencies here.
That sounds right.
We have a motion on the table.
All in favor?
Aye.
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 You have it, Zach?
I got Dr. Pond, Dr. Williams, Dr. Katz.
Dr. Gerling.
Yeah, brother too.
All opposed? Any abstentions? Okay, motion passed. Sorry, go ahead, Dr. Pond.
No, just other new business.
RSI, I really have no more RSI updates for anybody. We are stuck on trying to find a way to ensure this.
Dr. Gerling, I think you had wanted this on the agenda after the last meeting. I don't know if there's anything that you wanted to add.
Nope, I just wanted to make sure we keep pushing on this issue. Although, have any people been approached by the agencies to go ahead with MFI in the region?
Yeah, Cambridge is interested in it. I know they did start talking about it. I spoke to them about it.
Yeah, okay. And there are a couple of agencies on my side which were looking to do this. So I just want to make sure. And so, because it's been a while since we addressed this and where the particular roadblocks were to this happening, and then kind of furthermore, just to kind of expand on this, it would seem responsible if there's new agencies moving in an MFI direction, and given the current literature in terms of intubation with direct video versus direct, intubation, it would seem responsible for us to ensure that agencies, if they're moving ahead with the new MFI scenario, that they have the ability for videoscopic intubation, right?
We approved that as a REMAC. When we approved the RSI package, we talked about that as a REMAC, and we made video laryngoscopy a requirement.
Okay.
Not that it matters because we haven't moved since then, but
right.
Yes,
Okay, so, all right, so that's good. And so where are we in terms of, if any particular roadblocks in getting this done? Was this more in terms of training and getting the ability for medics to get adequate observed intubations? Was that the roadblock?
So,
Yes.
we thought we could solve this last year. And part of the package that we as a REMAC approved was that, RSI qualified paramedics needed to do at least 10 intubations of patients per year. One of the ways that they would be able to do that was to go to the OR and be able to complete some there versus the ER versus their actual intubations in the field. But their cumulative annual requirement was going to be 10. To be able to achieve that, they needed to be insured so that they could go inside the hospitals and practice intubation. We thought that we had gotten over that speed bump last year. Bruce Berry, who ran the Elizabethtown paramedic program, had created a course with New York State that had a course number that was qualified for CME, that he would be able to bring these paramedics into. And they would essentially become students, even though they're not real students. And they would be covered in that manner. Unfortunately, we lost Bruce Berry as the course director as the paramedic program, and so we're rebuilding this with the new course director, Josh LeDuc. If you guys have a different workaround, we're open to that. This does not have to go through the Elizabethtown paramedic program. That was just the resource I happened to have at my fingertips, and nobody else was coming up with anything else. But the door is wide open, and if you have a better workaround, please, let's do it.
Yeah, what I hear is that getting into the OR, impossible. Hospitals have no interest. They're just, let's be honest, for the most part, hospitals really aren't engaged that much in EMS. So is there a sim lab or something else that you could consider that maybe there'd be an opportunity there? That I think would be potentially good. So that's what I've heard is just good luck getting into the OR for those intubations. It doesn't happen.
I've got to tell you, we're not having trouble getting paramedic students into the ORs. We have great contacts. We've had really good luck getting students in. I don't actually think this is going to be as big a problem as everybody says, because we're having such great success with our paramedic students. And we're going to use the same pathway and the same clinical coordination. So I have heard that feedback as well, Dr. Broderick, but I gotta tell you, my personal experience is that that's not gonna be the case. And this is including Glens Falls ER and Amsterdam and like places that are more local to you guys. We're not having trouble getting folks in.
Okay, I'll bring that forward to the captain and say, let me know if you have roadblocks, but I don't have any teeth to.
First step is being able, like, if we can't insure them, then we can't even ask. And so that's the first step, is trying to get them insured. Any other RSI discussion? I'm happy if anybody has thoughts or concerns or anything else you want to work on, please get a hold of me. I'm more than happy to give it a whirl. Agencies and enlisted and listed medical director updates. Is that something, Zach, that is there stuff that you need to accomplish there?
So it
You
should
had a
have
question
been.
about Sable, and it's Dr. Mulvey, by the way. I found that one.
Okay.
So in our looking for things and at things and updating our own internal databases and whatnot, we found that there is a great deal of discrepancy between who the state has listed as an agency medical director, who we have listed as an agency medical director, and who the actual agencies have listed as their agency medical director. So we are working through this process. If there has been an agency medical director change and it is not reflective of what the state has listed, we will be sending you all collectively a packet for all of your agencies to fill out and do. The only place that we're really super concerned about this is with their narcotics forms and having those not be representative of who the agency's medical director is. I think just over the course of the transition from Travis to Ann to me, some of this has gotten garbled and fallen off. And this is me fixing it because I don't like it. I don't want to see an agency get jammed up because of stupid paperwork. So we will be sending you packets with your agencies. If you find that there's a discrepancy in that packet that we send you, then we will work through it and find who the appropriate person is for it to go to. If everyone is okay with that. Dr. Bond, you're muted.
I think that your list shows that there's huge gaps. There's doctors that actually resigned from this 2 years ago. So that anyone that does not have a current medical director now, I think you guys should call whoever they got listed and say, you need to give us a medical director, tomorrow. Because that is just plain insane. I can see maybe the state being messed up, but our list has got to be right. And we also have to know who the hospital representative is from the 5 general hospitals. And that should be on this list as well. And I think that needs to be done literally immediately, because I know there's 2 ambulances sitting out there that haven't had a medical director in years. So
we are working on it and we are trying to get things cleaned up. And I thank you all for your cooperation in this and as we move forward. And I also would like to thank you all for being patient with me as I figure all of this out. So thank you.
Well, thank you for all that work, because we just need to get it cleaned up.
Okay, and the one, I didn't see this actually on our new business agenda. However, we need to elect a chair. We didn't do that last year. And I was happy to stay on, but I think that we need to do that once a year. Thank you very much.
So we did receive 1 email nomination for Dr. Williams.
Okay.
So the question is, do you accept the nomination?
No. Thank you.
Can I nominate you again?
Thank you.
Any other nomination?
I presume you're already nominated? Like,
I mean, she's the
Yes.
sitting chair.
So we don't have to make a
You
nomination.
can't nominate her. You should nominate her. Or someone should nominate someone for a chair.
Yeah, we have to nominate somebody.
Is there any other nominations?
Nominate Dr. Baumgartner.
We have a nomination from Dr. Bombard. Do you accept?
I do. Are there any other?
So I'll say we asked 3 times, or any other nominations from the floor, and call for the vote then.
Are there any other interested parties before we just finish this? Is there anyone interested who want to do this?
I mean, Dr. Daly's hand is still up. We can take that as a self-nomination.
I do not know how to get it down, and I appreciate it, but I feel like I am new to this group, and I feel like there's a lot more I have to understand. So no, thank you at this time.
Maybe next year. All right. Can you call it?
Yep, we have a motion and a second. Call the vote. All in favor? Signify by raising your hand, because that's easier.
Aye.
Any against? So moved. Yours for another year. Congratulations.
Thank you.
Or commiserations.
Did you want to cover the conflict of interest form?
There's been no changes to the policies or anything like that. It was in the meeting material information. We just have to do it every year. So Dr. Bombard, Dr. Rome, since you're here, I'll make you guys sign it now. But if you guys need the policy again, I have paper copies here. Or I can send them out to you guys. I'll follow up with those. I think a couple people did turn them back in after I sent them out. So thank you to those that did.
That's the COI you're talking about?
Yeah.
Yeah,
Yep.
I just docu-signed and sent it to you. It should be in your inbox.
Yeah, if you could send them out again, I think I might have missed it. Thanks, Zach.
Absolutely.
Next meeting is August 26th. Any public comments? Anything else anybody needs to bring up?
Oh, wait a minute. Did we do old business?
That was the conflict of interest.
Okay,
And that's all the business
the other thing
we
I
have.
want to bring up is there was a letter that was supposed to go out to Essex County and Department of Health about not being able to do QA. Did that get sent to them or an email get sent out?
I'm waiting for a letter from the Bureau to back up our stance on that stuff should be made available to the medical directors, just so we have a little bit more teeth behind us.
Okay. Okay, thank you. So that should be added to old businesses left over. And I'd like to do, say two other things, actually, probably should have been under new business. We have an attendance list. We voted on this rule that if you miss 2 out of the last 4 meetings, you're off the REMAC. So we either need to enforce that or not. And if that list was sent out with our packet. I think that the people that haven't made it, Eric Rogers needs to be taken off. And there's some folks that would be in violation at this point. I'd like to see a letter or an email get sent to those folks that, the next meeting they'll be voted off if they don't show up. And I'll make that as a motion, because if we're going to have the rule, we're going to enforce the rule, in my mind.
Eric gave me a verbal resignation. Did he give that to you as well, Michael?
Yes, yeah, no, I specifically called him and asked him.
Can we accept that? I think I don't know that we need a written resignation from someone.
No, it can be verbal.
That's expressed it to both of us. So let's just take him off. And I actually didn't see anybody else in violation that wasn't excused, did you?
I think there's 2 people on that list.
Has
But we
Dr.
don't know.
Cardos been here for a while?
Oh, he's gone for years.
Oh, Katrina Cardos, I thought.
Katrina,
I heard
I mean,
her
she's
name.
still the director of Lake George, but I don't think she's been at a meeting, has she?
Not in years. And we actually
Not
removed
once,
her
ever.
as a couple of
Okay.
meetings ago.
Yeah, when we made the rule, she was one of the initial ones that was taken off with the large group.
I think everybody else was in compliance, if I recall correctly. I'm trying to find it again.
No, I don't think we need to do the names, but there's people that aren't in compliance. So I just think they should get a letter and we should move on.
Move on. Any other old business?
I'd like to also talk of one other issue, which is the problem that we had today with Dr. Mulvey. We used to have the ability to, assign somebody to kind of represent you at the meeting if you couldn't make it with, say, the real problem is these services that don't get approved for 3 months. I think we should have a system of proxy for that. Maybe they, could be just as simple as, one REMAC doc talking to another REMAC, like I called Mulvey and said, hey, it looks like you're not going to be here, so do you want me to represent you, same as I did for DRSA? So I think we actually ought to formalize that in one of our rules, though.
Could you, could you actually form that in the form of a motion?
I'll make a motion that at least for the approval of service ambulance services, that if a doc gets stuck and can't make it, he or she can call and let another doc know that they're comfortable and can can act as a proxy for that.
I'll second that. And, but we used to do it that way. We always had representation by proxy. So is that perhaps not already a written regulation somewhere?
Well, it may be, Doug, but
okay.
Somehow in my mind, I think that got nixed, and I'm not exactly sure why. But I think we should be able to have a proxy. But since we've lost all this stuff in the black hole of Mountain Lakes, I'm making the motion that we reinstate it, at least for the service part. I don't see any reason not to reinstate it totally, but we do need some system.
I agree. So I'll second that, especially for your agency approvals, that you can representation by proxy. Thanks.
Now, that does not count as attendance, is that correct?
Yes, does not count as attendance.
But it could be counted as an excused absence because it's unforeseen
An
circumstances.
excused absence is an excused absence.
Yeah.
But if you have an excused absence and you want to keep moving things forward, then please appoint a proxy and say to that proxy, hey, I have no problems with my services going forward. Please go ahead.
I'll type something up and get it out to everybody.
Thank you.
Yep.
Any further discussion? Any opposed to this motion? Motion carries. Anything else that we need to tackle today?
I hope not. My battery's at 2%.
All right. May I
How's
hear
our
a
computer
motion?
doing?
I hear a motion to adjourn.
I'll make the motion.
Motion to adjourn.
Second.
Thank you, everyone.
Thanks, everyone.